Good afternoon again. I am Dr. Kathie-Ann Joseph, and I really would like to again thank the Barbados Cancer Association and Dr. Parrish for inviting me back. It's been some time since I spoke to BACA, and I think at that time it was at Kingsbrook in Brooklyn when I spoke to the group many years ago, and really enjoyed continuing this collaboration, and also to speak about breast cancer in honor of Dr. Deborah Brathwaite. So I am a breast cancer surgeon at NYU Langone Health, and I'm going to speak today about the importance of breast cancer screening in Black women, particularly in the New York City area, and what we're doing to address the impact that breast cancer has had on Black women. So I don't have any disclosures. And what I'd like to start off with is sort of a little vignette that I often give when I talk about the impact that breast cancer has on Black women. A year ago, Mrs. W, a 41-year-old uninsured Black woman, presented to her gynecologist at her local clinic in a safety net hospital near her home. And then as part of her routine visit, her doctor referred her for a screening mammogram. Her screening mammogram is a BI-RADS4, and additional imaging is recommended. So BI-RADS4 means that there's a finding there, it's a little suspicious, and however, the patient wasn't told about this at the time of her visit. So 4 weeks pass, and her gynecologist receives and reviews the report. The gynecologist contacts the patient and explains to the patient she needs to return for the additional imaging. The patient calls the imaging center and they give her an appointment 6 weeks out. She returns for the diagnostic imaging, and a report is sent to her doctor again, which is received a month later. And this time it's a BI-RADS5. That means that it is highly suspicious for cancer malignancy. Doctor calls the patient urgently to explain she needs a biopsy. The patient is nervous, calls the imaging center, and receives an appointment 6 weeks out. She cancels her appointment because she doesn't feel anything is wrong with her breast, and she feels fine. She doesn't feel anything. So she later presents to the emergency room at her local hospital 6 months later with a palpable, meaning that she can feel it now. She feels a palpable 3-centimeter mass in her breast with palpable lymph nodes underneath her arm, axillary lymph nodes. And she is ultimately diagnosed with locally advanced left invasive, triple negative invasive ductal carcinoma. And so this is a story, but this is actually not quite uncommon, something that we see often, unfortunately, that happens given the healthcare system that we work in terms of what happens when we see women that are lack the resources and are uninsured, and often get pushed out in terms of their appointments, and also gaps in communication and care. So, hang on, I just lost my screen. Let me just pull it up again.
We can see it.
You can see it, but I can't. I'm not sure what happened. Okay, here we go. So
Right.
it's fine. I'm up now. So when we look at the incidence and mortality rates for breast cancer across different ethnic groups, Black women still have a 4% incidence, lower incidence compared to white women. However, the mortality rate is 40% higher. So if you look here, this is Black women here in the second group here. The incidence is slightly lower, although it is creeping up. So that's the number of women who actually get breast cancer across the board. But the mortality rates, and that's the darker pink, is the highest of all ethnic groups. So I just want to make sure that we are, so even though we're not getting it at the same rate, it's a little bit lower, we are disproportionately impacted by breast cancer. And from 2016 through 2020, the incidence of breast cancer was higher in Black women compared to white women in only 4 states in this country: Alabama, Louisiana, Mississippi, and Virginia. But the breast cancer death rate was higher for Black women than white women in every single state in this country, except Washington. So why is that? So for Black women younger than 50, they had a death rate that was twice as high as white women. But Black women are more likely than white women to die of breast cancer at any age. American Indian and Alaska Native women are also 17% less likely to be diagnosed with breast cancer than white women, and also 4% more likely to die from the disease. Part of the reason the breast cancer death rate is not dropping as fast as it has in previous years is because the screening rates aren't keeping up. And so too few women are receiving timely and high quality treatment after they're diagnosed with breast cancer. And so this slide, and this is taken from the American Cancer Society, shows the survival rates across all stages and race ethnicities from 2012 to 2008. And this darker pink is white, the white population, and the light pink is Black women. And this is all stages, whether you look at all stages, localized disease, regional disease, or distant disease, that's what we call metastatic, or those that are unstaged, Black women have the lowest survival rate here, 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 and here. So we just do worse across all subtypes of breast cancer. One of the things we need to look at and consider when women are diagnosed with breast cancer is, or for screening, is risk factors. And I say this all the time, we need to know what our risk factors are. And risk factors are anything that can increase or decrease a person's chance of getting a disease such as cancer. The thing is with breast cancer is most women, 90% of all women with breast cancer, have no identifiable risk factors. So when I am sitting in my office with a woman with a newly diagnosed breast cancer patient, they say, I don't have a family history. No one in my family has had it before. Well, they're no different than most women that I treat that are diagnosed with breast cancer. However, there are some risk factors, known risk factors, that are identified with breast cancer. Some of these we can't change. We're just born with it. But there are some that we can modify, we can change. The main risk factors for breast cancer, you cannot change, but you need to be aware of. Some of them, of course, are being a woman, getting older. Your risk goes up as you age, and also genetic changes. Other risk factors, race and ethnicity, inherited genes, your family history, extremely important. I'm going to go into that. Your breast density, and some benign breast conditions that can predispose you to getting breast cancer in the future. Also, softer risk factors like when you start your menstruation before the age of 12 and going through menopause after the age of 50, because that has to do with prolonged cycles of unopposed estrogen. So what can you do to lower your risk for breast cancer? You can maintain a healthy weight. It's very important to exercise. Do what makes you, do what you enjoy, whether it's dancing, walking, riding a bike, any type of movement. Very important to exercise. Limit your alcohol intake, limit smoking, stop smoking. And I tell all my patients, this is good not just for your breast cancer risk, but for your overall health. limit menopausal hormone use. And the one thing that I tell younger patients, or the younger women, is breastfeeding. It's good for the baby, but it's also good for the mom. That is actually a good thing that prevents breast cancer, helps to prevent breast cancer. So it's important that all women know their risk. It's important to talk to your family members, to know your family history. Many people don't know what, sometimes we don't like to talk about cancer or share what a family member died from, especially with cancer. And not just breast, but other types of cancer that can be associated with genetic risk factors like ovarian cancer or pancreatic cancer, because it is still a problem in our community. So know your risk. And also it's important to get screened. It's important to examine your breasts so you know what's normal for you. It is normal to have to have lumps in your breasts, as long as that is normal for you. And make healthy lifestyle choices. So what we're doing at NYU to increase the screening rates, particularly in medically underserved populations, is in 2016, we launched the Beatrice W. Welters Breast Health Outreach and Navigation Program. And we wanted to ensure that women would have access to low cost or free mammograms, and also provide active support from diagnosis through treatment and on to survivorship. And we use navigators that are from the community themselves to assist these women through the process. And ultimately want this to be a model for other cities to follow. And this is our geographic reach, which is essentially all of New York City, but we really focus in on several areas. One is Harlem. The second is Lower Manhattan, where NYU and Bellevue is located. And also the second is Brooklyn, where we have NYU Brooklyn. And to achieve this mission, we have a tripartite mission. The first is outreach, and we have really worked to leverage and build relationships over the years with community-based organizations. And we have navigators that work with local churches and beauty salons and other community sites. They also do mammo vans. Anywhere we're invited, we will spread the word and enroll them into our program and make sure that they get access to screening mammography. And education. We have developed and distributed educational materials that patients can understand and are translated into several languages. And then obviously the last part of this is navigation. And it is important to us that we are navigating them not just to screening, but through screening, and if necessary, through the entire treatment continuum, including clinical trials and research if necessary. And we've been very fortunate to partner with some of these really great programs throughout New York City that help us, because to support these patients, we recognize that it's not always easy for patients to get through, to get to screening and also to get to treatment because of barriers, whether it's transportation or whether it's housing insecurity, food insecurity. And with the help of our partners, some of which you see here on the screen, we've been able to really help to, we document these barriers, but we also, more importantly, we work very assiduously to overcome these barriers so that patients get to screening, and if they're diagnosed with cancer, we're able to surpass these barriers to care. These are the top zip code neighborhoods that we service. This is not all the neighborhoods, but these are the neighborhoods where we draw most of our women. The top being East Flatbush in Brooklyn, and then Flatbush, Sunset Park, Harlem, and Brownsville. Now that Harlem was the last neighborhood to come on board, and we really, our navigator there has really ramped up quite a bit. And I'll just finish up by just letting you know, this is our team, led by Megan Hasseltine, our administrative director. Anita, we could not do this job, run this program without our senior manager, who sort of is the engine that really keeps the train running, and oversees our navigators, and Janya Jean-Francois, our coordinator. And these are our navigators, and many of them are bilingual, if not trilingual. Sheila, Jackie are 2 senior navigators, along with Patricia Hepburn Moody. And we have Rachel John Louis, excuse me, who's based in Long Island. And we have a physician assistant, Yulia, and Mike Howell, our data analyst. And as I said, it's important to provide comprehensive care. We don't want to enroll patients into our program and not be able to provide all the necessary care that these patients require. We have access to genetic counseling. Many patients seem to think that it's only when we think about genetics, we think about BRCA1 and BRCA2, and that it's only a white woman's disease. That's not true. We don't know unless we test, and these genetic predispositions are found in all ethnic groups. And so we have a really robust team here, led by Forum Shah, but we also have Sarah that we brought on as well to do genetic counseling for patients, and to make sure that they get the care. The testing, counseling and testing is needed, even irrespective of insurance. Say just thank you, and I would want to leave this number if anyone needs information. And I was just going to say, share this with information with anyone you learned today with someone you care about.